Hi everybody and welcome to AARC's Big Ideas Theater. I'm your host, Ed Hyland. I'm joined now by Kevin McQueen. He's the speaker for Monday's session on reducing nuisance alarms. Kevin, thanks so much for coming by and joining us.
Thanks for having me.
Let's go right down the list here and get to it, talking about how did we get from having clinical alarms as a patient safety tool to the point where excessive clinical alarms can actually lead to some patient harm.
Well, back in the early 80s, we only had a small number of devices that had alarms. About 5 or 6 different devices had alarms to alert clinicians of problems with their patients. Over the years, about 30 years, and in 2016, we now have about 40 different machines with numerous alarms. I mean, some devices have up to 100 different capable alarms they could alert clinicians of problems. And that has lent an issue where clinicians that are trying to work and take care of their patients are constantly hearing alarm sounds. So it ends up being similar to when you're around a child that just keeps nagging at you over and over and over again. Sooner or later that leads to like a mental overload. And clinicians literally no longer pay attention to the sound. Probably the most common one that we see in a hospital is the IV pump. And they tend to beep so often, and there's no real clinical indication of why they need to go in there. There's nothing life-threatening. It's just to alert them that maybe the the bag is running low, or the patient moved their arm. But there's no real risk to the patient. Well, that endless noise has led to the staff literally no longer hearing it. So you can walk up to a nurse in a hallway, and she'll be talking to somebody, and you'll ask her, do you have the patient in that room right there? And they'll say, why? And you say, well, the alarm's going off. And they'll say, they don't even notice it.
Right.
But the patients notice it. So over time, we have endless alarm after alarm, and it's really leading to severe fatigue mentally to the clinicians, to the point where they don't respond as fast, or they literally don't hear them. And that's what puts patients at risk.
And a quick aside, I was just in the hospital with my dad doing some of the same thing. Alarms are going off. He's almost 90 years old. And I asked the nurse and the respiratory therapist when they came in, what about all these alarms? Oh, well, don't worry about those. So it also worries the family, not just the patient.
Yeah, and that's usually where I come in. As I'm a patient safety officer and a risk manager. So when I walk through the hospital and I hear the alarms, I look in the room, and usually what I see is an unhappy patient and an unhappy family member staring, waiting for someone to respond. But about 90% or greater of all alarms that go off in a hospital are nuisance alarms. They are not required to be responded to by a clinician. They just need to be silenced or reset. But if you have a clinician knowing that 90% of the time or more, they don't need to respond, they won't respond. If it got down to where we had only about maybe 10% of the alarms really were actionable items where the therapist or the nurse or the doctor had to respond and do something, if they knew that only that small amount of alarm was real, they'd respond all the time. But what they're getting is this huge inundation of noise, and sometimes they're getting up to 100 or more per patient per day. So it just gets overwhelming into where the people are numb.
It's overload, absolutely.
Yes.
Well, give us some of the ideas of what are some of the means that hospitals may utilize to perhaps conduct risk assessments related to clinical alarms.
Right, as a risk manager, one of the things I often do is come into facilities or even at my own hospital, is I've learned that when it comes to alarm management, it's very much unit specific. Every unit has its own alarms that sound more common than other ones. So we have risk assessment tools that are available that are very simple to use, where you go through every single department and you go over every device they have that alarms, and you meet with the clinicians that are that truly are the end users, and you say which ones are the most critical, meaning that if you don't get alerted, what risk is there to your patient? And then you work your way down to the least, where you really don't need an alarm. And then you say how frequently they're alarming. Is it all the time or is it rare? And then you can rate them as a criticality, and you can literally put them on a spreadsheet to say these are the most risky, these are the least risky. And then we focus on working with the clinicians to figure out, are there ways for us to reduce the nuisance alarms on those high-risk devices so the staff will trust them more? And then we have to do risk assessments on their ability for the staff to be able to hear. When I first got into alarm management, I truly thought that all alarms could be heard in all areas. And when I asked the clinicians during our original meetings and we started asking them, can you hear all the alarms at the nurse station? They said, oh yes. But when we went around into every single patient room and tested the high-risk devices in every room with the door open and the door closed, We found out that in certain cases, about a third of the alarms that are furthest away from the nurse's station, they literally could not hear with the door shut. So you could have, and at nighttime, they don't want to disturb the patient, so they're shutting the doors. Well, that means that nurse is all the way down the hallway, or the therapist all the way down the hallway, they may not hear that critical alarm. So by doing that, we were able to make spreadsheets to teach the nurses and post them and say, these are your high-risk rooms. Know that you cannot close the door, or you need to set the ventilator, you need to set the pulse oximeter or other device to a higher volume level so that you will be able to hear it to the nurse's station.
Give us an idea of some of the evidence-based changes that can take place that hospitals can utilize, as well as RTs, to make this a little more effective and efficient operation.
Well, once you figure out what your high-risk alarms are, and then you realize what your most common nuisance alarms are, you start looking at the literature. Simple things like hospitals that are consistently changing the electrode pads, the low EKG pads, and they're consistently doing it on a daily basis, have been shown to reduce their nuisance alarm by up to 47%. One common thing with respiratory therapists, and even with nurses, is studies have shown that if you have a lead therapist or a charge nurse remind the clinicians every day to go and assess their patient's alarms and adjust them to that patient's needs, it can reduce the alarms 24 to 43%.
Wow. So simple steps can
simple
make big
things.
changes.
Adjusting pulse oximeters, and this is pretty commonplace with most therapists, but for years most hospitals set the alarm to alert at 92% or 90%. But a lot of hospitals have been very comfortable, and the research has shown that if you drop it down to 88%, some hospitals even go lower, maybe to 86%, and put an alarm delay of about 15 seconds, it will reduce dramatically the number of nuisance alarms. And you just have to decide how risk is it to the patient in that area, and that's why I always say it's unit specific. If the patients are relatively stable and you're monitoring them, maybe you feel more comfortable dropping it down a little bit lower. But if they're a little bit more unstable, you don't. So it's really teaching the clinicians that there's a lot of risk associated with clinical alarms, and they have to be proactive. They can't just put them on, leave them on the default settings, and hope for the best when they're going to get inundated with alarms, nuisance alarms.
There's the key word, proactive, be involved.
Proactive.
Kevin McQueen, thank you so much for joining us here in the Big Ideas Theater.
Thank you, it's been a pleasure.
And this is the Big Ideas Theater at AARC. I'm Ed Hyler.